For more than 40 years, a class of medications known as beta blockers has been a cornerstone of care for people who have survived a heart attack. Doctors prescribe these drugs with a clear goal: to protect the heart as it recovers. Beta blockers work by slowing the heart rate and reducing the force of its contractions, which lowers blood pressure and eases the overall workload on this vital organ. This gives the heart muscle precious time to heal after the trauma of a heart attack, which is medically termed a myocardial infarction. The logic has always been that by shielding the heart from stress, we can prevent future cardiac events and improve a patient's long-term survival. The use of beta blockers became standard practice based on studies from decades ago. Back then, the treatments available for heart attacks were far less advanced than they are today. Procedures like angioplasty and stenting, which physically open blocked arteries to restore blood flow, were not widely used. In that era, heart attacks often caused significant and permanent damage to the heart muscle, leading to a condition known as heart failure, where the heart can no longer pump blood efficiently. In those specific circumstances, beta blockers proved to be incredibly effective at saving lives, and they rightfully earned their place in our medical guidelines. However, medicine is an ever-evolving field, and we must constantly re-evaluate our long-held beliefs in the face of new evidence. The landscape of cardiac care has changed dramatically. Thanks to modern interventions that quickly restore blood flow, many people who have a heart attack today experience much less damage to their heart muscle. Their hearts often continue to pump blood quite well, a state we refer to as having a preserved ejection fraction. This raises a critical question. Do patients with healthier, well-functioning hearts still need the same intensive beta blocker therapy that was designed for more severe cases from the past? This very question has become a subject of intense debate and new research within the cardiology community. As our ability to treat the initial heart attack improves, we must also refine our strategies for the care that follows. It is no longer enough to assume that a treatment that worked for one type of patient 40 years ago is automatically the best choice for every patient today. We are now entering an era where we must look closer at the individual patient, their specific level of heart function and other personal factors to determine the most beneficial and safest path forward, challenging that the one-size-fits-all approach to post-heart attack care. To address this modern medical question, researchers in Europe recently conducted a large and important study called the Reboot trial. The findings, published in the prestigious New England Journal of Medicine in August 2025, have sent ripples through the world of cardiology. The study involved over 8,500 patients from 109 hospitals across Spain and Italy who had recently suffered a heart attack. Critically, all of these patients had what doctors call a preserved left ventricular ejection fraction, or LVEF, which means their hearts were still able to pump blood effectively. This is a very common scenario in hospitals today, making the study's results highly relevant to millions of people. The design of the trial was straightforward but powerful. The researchers randomly assigned these patients into two groups. One group received the standard treatment, which included a daily beta blocker, while the other group did not receive a beta blocker. Both groups were then followed for a median of 3.7 years. During this time, the scientists carefully tracked whether the patients experienced another heart attack, were hospitalized for heart failure, or passed away from any cause. The central question was simple. Did the beta blockers provide any additional protection for these patients whose hearts were already functioning reasonably well after their initial attack? The results of the Reboot trial were quite surprising and directly challenged decades of routine medical practice. The study found no significant difference between the two groups. Patients who took beta blockers were not any less likely to die, have another heart attack, or be hospitalized for heart failure compared to those who did not take the medication. In other words, for this large group of heart attack survivors with preserved heart function, the beta blockers appear to offer no measurable benefit. This finding suggests that the automatic prescription of these drugs for this specific patient population may be unnecessary. This conclusion forces us to reconsider long-standing medical guidelines. The protection that beta blockers offered in the past, when heart attacks caused more severe damage, does not seem to apply to patients who emerge from a heart attack with their heart's pumping ability largely intact. While the study did note a potential small benefit for a tiny subgroup of patients with only mildly reduced heart function, the numbers were too small to be conclusive. The main takeaway was clear for the majority of patients with preserved function. Beta blockers did not seem to help prevent future cardiac problems, opening the door for a major shift in treatment protocols. As researchers dug deeper into the data from the reboot trial, they uncovered a more specific and alarming finding. In a separate analysis published in the European Heart Journal, they focused exclusively on the outcomes for women. About 20% of the study's participants were female, and when their results were isolated, a troubling pattern emerged. Unlike the neutral outcomes seen in the overall study population, for women with preserved heart function, taking beta blockers was not just unhelpful, it appeared to be potentially harmful. This discovery has raised serious concerns about how these common medications may affect men and women differently. The sub-analysis revealed that women in the trial who were treated with beta blockers had a 45% higher relative risk of a major negative outcome, death, another heart attack, or hospitalization for heart failure, compared to women who were not given the medication. This increased risk was primarily driven by a higher rate of cardiac-related deaths among the women taking beta blockers. Specifically, the risk seemed most pronounced in women whose hearts were functioning very well, with an LVEF of 50% or higher, and in those who were prescribed higher doses of the medication. This is a significant and unexpected finding. When comparing the outcomes between sexes, the contrast was stark. While women on beta blockers faced this elevated risk, the same harmful effect was not observed in the male participants of the study. For men with preserved heart function, the beta blockers were simply neutral. They neither helped nor harmed. This discrepancy underscores a critical and often overlooked aspect of medical research. Men and women can respond very differently to the same treatment. The study did note that the female participants were on average older and had more other health conditions. But even so, the signal of potential harm was strong and warrants immediate attention. This sex-specific finding is a powerful reminder that medicine must move beyond a one-size-fits-all model. For decades, medical research has often been centered on male physiology, with results simply extrapolated to women. This study shows the potential dangers of that assumption. An absolute risk increase of 2.7% in mortality over nearly 4 years, as seen in this study, is not something that can be ignored. It suggests that for a woman recovering from a heart attack whose heart is still strong, prescribing a beta blocker might not be a safe default strategy and could, in fact, be a step in the wrong direction. The groundbreaking findings from the reboot trial and its sub-analysis on women are poised to change the way doctors think about care after a heart attack. These results challenge the universal application of guidelines that have been in place for over 40 years, suggesting a more personalized approach is needed. International medical societies will likely need to review and potentially revise their recommendations, advising doctors to be more selective when prescribing beta blockers. Instead of an automatic prescription, the decision may soon depend on a patient's specific heart function, their sex, and other individual health factors. It is crucial for the public to understand what these findings mean and, just as importantly, what they do not mean. This research applies only to heart attack patients whose heart muscle function remains preserved. For patients who suffer more significant heart damage and develop heart failure or reduced ejection fraction, beta blockers are still a proven life-saving therapy. Therefore, it is absolutely essential that no one stops taking their prescribed medication based on this news. Any decision to change a treatment plan must be made in careful consultation with a doctor who can assess your individual health situation. While this research provides valuable new insights, it also highlights existing gaps in our knowledge. The fact that only about 20% of the study participants were women underscores the urgent need for greater inclusion of female patients in cardiovascular trials. We need more research designed specifically to understand the effects of treatments on women, who often present with different symptoms and have different outcomes. Furthermore, since the study was conducted in Spain and Italy, we need to see if these results hold true for more diverse populations in other parts of the world before we make sweeping global changes. Ultimately, this new evidence marks a positive step toward a more precise and intelligent era of medicine. It reminds us that good science is a process of constant questioning and refinement. By identifying which patients truly benefit from a therapy and which do not, or may even be harmed, we can deliver safer, more effective, and more personalized care. The conversation about beta blockers has been reignited, and it will hopefully lead to better outcomes for all patients, ensuring that every treatment we prescribe is based on the best and most current evidence available for that specific individual.